just look at this optical illusion, okay? You can see multiple things in this picture. Now, you can see those big faces there, and then there are two people who are sitting there. One is playing the music, okay? Now, you can see them all, but I want you to see the person who is playing the music and the big face together. That means simultaneously. Can your brain see that? Okay. What happens when we are looking at the picture, when you want to look at that, person playing guitar, your brain only acknowledges that. Though your brain knows that there is something like a big face which exists, brain, does not want to see that, and you see only that. So brain very quickly, changes from big face to small, that figure which is there. That is how exactly the trifocals work. That means all the images from distance as well as near are in focus. Our brain decides which one you want to look at. Okay, so we'll go to the, so this is how even the extended depth of focus technology work, but little differently because it elongates the focus. So it's basically a polyfocal IOL, I would say, rather than a, just extended depth of focus IOL. So these were the initial multifocals which came into market when even I was not in the practice. These were the refractive multifocals, and they went out of vogue initially because there was a lot of loss of energy, and that meant that there were a lot of dysphotopsia and loss of contrast. Next generation trifocals and multifocals came where they reduced this loss of energy. But again, loss of energy means loss of contrast. So you are seeing things less bright. So now the new extended depth of IOLs have come, which are going to give much less reduction of the light. So you can see in this optical bench testing, the one, for example, the Lentis M+, you can see how the light is, seen there. While in case of the multifocals, refractive as well as diffractive, there is diffusion of light or loss of light, which is there. So that's why you have much brighter focus of light in extended depth of focus IOLs. So this is a comparison of light loss in different IOLs. You can see that in the multifocals, either refractive or diffractive, there is much more loss of light as compared to the extended depth of focus IOLs. And as I told you, for example, this middle segment shows the extended depth of focus IOL, and it's quite comparable with the monofocal vision if you see the distance, because the contrast loss is not there. But if you see the trifocal, obviously there is contrast loss because of loss of light and aberrations which are created. You can see this is how the patient sees when a pointed light is shown to him. So you can see the upper figure where the trifocal shows a lot of glares and halos, while the extended depth of focus there is much less. And the lower one, it actually shows the M+ lens, EDOF lenses aberration. You can see there is only half part which has some aberration, but which are much less than the glares and halos which are seen in trifocals. So trifocals come with these complementary glares, halos, and starbursts, which are much less experienced by the patients who have EDOF. Again, example of multiple ways how the point source is seen by the patient. Even I would like to show the Symphony IOL, which is diffractive EDOF. So it's more of a diffractive multifocal with low ad rather than a EDOF. It also shows the glares, as you can see there, and halos. But you can see the Lentis profile, it is having much less glares and halos as compared to others. Let's look at different types of EDOFs, and then the particular IOL will be discussed by the experienced surgeons. So the first one is monofocal EDOF. We commonly know IHANS and magnificent IOL that we use commonly. So this is not actually in real terms extended depth of focus. They have just played with the positive spherical aberration of the lens. And the issues with this is that when you do the bench testing with these IOLs, you cannot go above around plus 1.2 diopters of addition. That's why this enhanced depth of focus IOL, for example, IHANS gives around plus 0.6 depth of focus addition to the monofocal, because monofocals also give around 0.5 diopters of extended depth of focus, and 0.6 addition to that is given by the IHANS, while the magnificent will give around plus 1.1 additional depth of focus, which are much less even for intermediate vision, I would say. And they will also have some blurring effects. So if the patients have small pupil, then these positive spherical aberration, enhanced depth of focus IOLs will create some blurring for the patient. The second one is the diffractive EDOF. As we know that they came initially into market, Symphony and AT Lisa, Lara are the example. But again, I would consider them as more of a, the low ad multifocals rather than actually a EDOF, because they were associated with loss of light and as well as glares and halos. Then came the aberrational EDOF, which Dr. Nitin will be speaking about. It's the Minivel, the example of it. So they played with different zones, and they played with the spherical aberrations of these zones, and these aberrations provided a depth of focus. Pinhole EDOF is not yet launched in India, but launched in probably European and American markets, and it gives almost up to +3 diopters of the depth of focus. It also negates some amount of astigmatism, but it reduces the, again, light that is entering the eye, so you may be able to use it only in one eye maybe. Polyfocal EDOF, again, it has not entered yet Indian market, and again it is basically it gives very high addition in the center, and then it goes reducing in the periphery, giving very high near addition power, but again it will have its own disadvantage along with it. And then there are refractive EDOFs, where there are refractional zones inside the lens. So one zone is for the distance, another is for intermediate, and maybe for near. So these are the overall different types of EDOFs. And so after this introduction, brief introduction, I would like to ask, I think, Dr. Nitin, you will be. Okay. So I would like to request Dr. Kumar Doctor. He will be speaking about his experience with EDOF IOL technology, and I'm sure he will be able to answer a lot of questions we have. Avi?
First of all, thank you, SOURABH, for this opportunity. I think a lot of us are shifting to various kinds of IOLs because of complaints from patients. So I'm just going to show quickly the tips and tricks, what I'm learning as far as this new lens. So is there any technique you need to change? Now I'm going to talk about the Lucidis EDOF IOL, which I'm using quite a bit. I've not used the Minivel, so you'll hear that from the other speakers. So the steps to change, the technique of loading, how to view it under high magnification, how to get the right size CCC, viscoelastic removal, injecting the IOL and unfolding the same, and how to handle the trailing haptic, and finally the viscoelastic removal. So this is the injector system that comes with the IOL itself. Of course, we fill up the thing with methyl cellulose. I like to fill up the bag with a viscoelastic, and it's a hydrophilic lens, not a hydrophobic lens. So this is the way the cap really comes. Once that is done, you hold the lens and place it inside the injector like we all do always, and close the cartridge and then push the lens into the eye. So it's as simple as loading any other IOL. There is no real technique. You will never get that haptic getting stuck between your plunger and this thing. That never happens, so that's not an issue at all. Yes, you have to place MMC, that is methyl cellulose, till the end of the injector. Otherwise, if you lose the plunger, sometimes air bubble will come because it's got a spring. If your spring, you lose the action, the air gets sucked into the cartridge, so it's very important. So you can see here that one of the videos I'll show, this is putting Helon. I'm not using GV, no financial interest. Filling up the bag, pushing the posterior capsule away. Many people like to do it under irrigation, whatever choice you want. I always like to do it under this. Now you can see the air bubble coming first. Now this air bubble has come first only because I lost the plunger, which has got a spring action, and that's the reason why it comes out first. So this can happen. If it does happen, now there's a trick on what to do, and then so that it does not happen the second time. And then just put the IOL into the bag. So I'm going to keep showing more and more cases. Again, you'll see a little bit of air bubble coming here. Of course, injecting through the main incision, even a 2.8 or 2.2 will do. The whole plate, it's like behaves little like a plate haptic design. The leading haptic has gone inside the eye, and now the trailing haptic. Now, there are many ways of putting the trailing haptic into the bag. One way is just placing it in, two is dialing. We are all used to dialing IOLs. But this doesn't work so well as far as dialing goes. So you saw that I actually moved it a bit and then put it into the bag. Why it doesn't, it's not as easy to dial this IOL. The main reason is because the area of the optic to haptic is very, very large compared to our Technis 1 IOL or the IHANS IOL or the IQ IOL. The optic haptic junction is very, very small. So that's the reason why it's very easy to dial those lenses in. These lenses are not all that easy to dial. Now this is again the leading haptic opening into the bag. Once that is done, now I'll show you how we dial this like any other IOL. You hold the optic haptic junction and dial it into the bag. So you can see that there is a larger area to be covered, and I'll show that again in another animation, that why is there, but that's the design of the lens. Now coming to viscoelastic removal, this again compartmentalizes the viscoelastic removal in front and behind. So we remove the viscoelastic from the front, it automatically comes out. I always like to go behind the IOL and remove the viscoelastic from behind the IOL too, because it compartmentalizes the viscoelastic in front of the IOL and behind the IOL. So I always like to go behind the IOL with irrigation. There are many ways of removing it, but it's important that we go behind the IOL and remove the viscoelastic. So that is one crucial step. So here you can see that I'm going behind the IOL with irrigation and just lifting the IOL, and that itself removes all the viscoelastic. So really there is no other effort, but we have to remember that that viscoelastic from behind the IOL has to also be removed. So sometimes the leading haptic behaves a little differently. Now watch what is happening, and I'll show you a video why it behaves like that. So you can see that the leading haptic is opening little downwards. Okay, so this can be a little scary initially, but there is a reason why this happens in this design. So this is what I've been telling the company people as to why this happens. I've further analyzed it and understood that what is really happening in the injector and the cartridge system. So here I'm just adjusting the leading haptic, make sure that the entrapment that had happened along the CCC margin is actually removed. So you saw that I disengaged that and made it straight. Once that is straight, now you can see that I made it straight, and then I push the optic down so that it becomes straight, and then coming to placement of the trailing haptic into the bag. So here, as I mentioned, yes, you can dial it in, and when it comes to dialing, I'll show you again that how much area has to be covered as far as dialing is concerned. So here I've made sure that the dialing is done like our normal pattern that we are used to for dialing IOLs into the bag, which we are used to for so many years, and we continue to use the same pattern. So here you saw that I put the haptic straight into the bag by dialing the whole lens and making the lens horizontal. Coming to watch this video, and that is the reason why dialing is a little tricky. So over the number of years, I've changed my technique and made another technique and made it a little more easier. So you can see that this is the optic, but the optic haptic, there is no small junction. It's a long area that you're covering. So you can see the optic, and then it continues with the haptic, like in a continuous form. So you can see this. So this is a huge area for the lens to be dialed into the bag. Our optic haptic junctions are much smaller in Technis 1, IQ, or any other case you take. We are much easier to dial them in. So you just hold the optic haptic junction and they go in. So this I've realized over the number of years of experience with these IOLs, and I've realized that dialing may not be the best thing to do for this IOL. So you can see the same area has to be covered, optic, then the whole haptic, and then place the haptic into the bag. Now the question is there any other technique of putting this IOL into the bag? Now you'll see no air coming, okay? The reason no air is coming because I didn't release my plunger. There was no negative pressure. There was no suction of air. Now I'm doing a bimanual technique. So in my left hand, you can use either a Sinskey hook or an iris repositor, whatever you like. I straighten my haptic at the same time, okay? So I'm preventing it from getting engaged into the CCC at the same time. So it's guiding, and now I'm releasing the superior haptic into the anterior chamber. And once that is done, as I said, there are many ways of putting the other haptic inside. Now I'm using, this is a T. A lot of people don't use this instrument. A lot of doctors use a Sinskey hook to dial the IOL into the bag. I somehow never understood that why, but here I'm using a T to put the optic haptic junction into the bag, make the IOL horizontal to prevent negative dysphotopsia, and this makes sure that the IOL is perfectly well centered. As far as the viscoelastic removal is concerned, the technique remains the same. Bimanual IA, remove the viscoelastic from the front of the IOL, and then go behind the IOL and remove the viscoelastic from behind the IOL. Now, the question here is, this is the new trick that I'm using. I'm using a iris repositor in my other hand, okay? So there has been one incident in my career where this IOL has flipped. So it can flip, Okay, if someone tells you it has never seen, never happened, then they've never used the lens. So how to prevent that from happening is the left hand, whichever instrument, your righty, lefty, whatever it is, the other hand will be making sure that the lens opens straight. And now this technique I'm using routinely. So I have an iris repositor. I'm not dialing these IOLs into the bag. I'm placing them into the bag. So you saw that with the repositor itself, I just moved the haptic into the bag. So I don't need all that effort to travel to make sure that the lens. Now, this is a toric IOL. The big advantage of, I don't know if you know, the Technis torics cannot be rotated anti-clockwise. They have to be rotated clockwise. Because if you rotate them anti-clockwise, that IOL may come in the way. Here the design of the haptic is such that they can be rotated anti-clockwise. So you saw that I'm actually rotating it anti-clockwise. With video, and I'm making sure that the axis is perfectly aligned. And now the viscoelastic removal from the front of the IOL. The question here is, why does the IOL behave like this in the eye compared to any other IOL? So I was also wondering why this actually happens, and actually I have a video to show that. So we tried to do a dry test and put it on different injectors. Now if you have a Technis 1 or an IQ, when the IOL comes out of the cartridge, it never goes below the plane of the cartridge. I hope you understood this. The IOL comes out straight, but the IOL never goes below the circle of the cartridge. That is the lumen of the cartridge. This IOL behaves very differently. And that is something to do with the design. When I tell them, they've accepted it, but MedCell has not been able to redesign the injector. So that I also, some people try Rayner. Some doctors are very happy with the IOCare injector for these IOLs. So let me show you. Now the IOL is coming out. Now you can see the IOL coming out. Okay, this is outside. And now let's pause this. Now when you see this area, and this is the lumen of the cartridge, this haptic is actually below the lumen of the cartridge. It's like this. So the cartridge is here. The cartridge is here. I'll take 30 seconds. The cartridge is here. Okay, this is the cartridge, and the haptic comes out like this. And that's the same thing that is happening in the human eye. Okay, because it goes like this and then it opens like this. So if we can somehow prevent this going down below the lumen of the cartridge, all these issues will be sorted. So, but I have not been able to solve it. So you can see now the haptic is looking down. That means it's looking towards the posterior capsule. One way of avoiding this problem is do a wound-assisted insertion of the IOL. Don't go till the CCC. When we are injecting a Technis 1, an IQ or an IHANS, our cartridge tip is right at the CCC, and then we are putting the lens into the bag. Here, one way to avoid all these headaches, what I showed you, is to start injecting the lens, and your cartridge will be exactly at the lumen of the wound. And if you do that, then even if it goes down, it's not going to damage your posterior capsule. So this is what I have understood. But basically, conclusion, it's a brilliant product. Hold on to the plunger so that the air does not come. Size of the CCC in femto may be 5.25. I normally do a 4.9. Fill the bag with viscoelastic depending on whatever technique you're used to. Bimanual technique to implant the IOL, as I showed you, either with a Sinskey hook and iris repositor in the other hand. Dialing the IOL, don't forget that the long surface area, so better could be that you just place the IOL. Viscoelastic removal from behind the IOL and in front of the IOL is necessary. In high myopes with larger bags, overall diameter may not be good enough. So if you have a very high myope and you have a bag size which is very, very big, this has a fixed plate haptic design. So sometimes these IOLs, if they are toric, may rotate. And this is very well known with the Zeiss lens, we know that. But IOL stability and rotation is very good. I've done some studies on the glerometer. I've also implanted the new lens which they're getting approval for, which is the Eden lens, which is the diffractive design and not a refractive design. The Lucidis is a refractive EDOF lens. Excellent results for distance and near. Thank you very much for your attention.
Thank you so much, and thanks for those surgical pearls, because these are really important because it's a different design of IOL than the routine hydrophilic or hydrophobics that we use. I would like to request Dr. Nitin to start the next presentation. In the meanwhile, sir, because you will be going a little early, so just a minute on what is your experience and about this IOL.
See, I will, nothing is honky-donkey in ophthalmology, so nothing is very perfect. So if I have to speak the truth, I've used about 350, not many, but some of them, okay, do complain like any multifocal IOL. Now theoretically, we are going to the diffractive to the refractive platform. So theoretically, we are going backwards. Our original refractive multifocal IOL was called Array. Some of you might have used the array. Yeah, you would have used the array. FDA approved refractive design, never did well in Indian eyes, and it was taken off the platform. As far as my results are concerned, yes, about 95% or maybe more are very happy for distance and reading. They do read N6. Some of them complain of halos while reading, maybe 2, 3 in 100. Then what is surprising is they say double, double, double. I just give an ad of 1.5 and the halos disappear. So I don't know why some of them are behaving like this. I don't know whether it's the pupil, because refractive IOLs are pupil dependent. Although we are looking at the pupil size, we are looking at scotopic, we are looking at photopic, somehow some of these patients are unhappy for reading. And I don't know whether the panel would like to share their, do they agree with what I'm saying?
Yes, I think perfectly. We'll move on to Nitin's presentation for lack of time. But just before, just one word about the type of EDOFs that we see. There are 3 types, though I missed the slide, I think. Yeah, he will be speaking. There is center near, center distance, and then asymmetric profile. So these are the things. So lucid is the center near. That means central part is for near. So that's why these issues come with these kind of IOLs. Dr. Nitin will speak about another type of IOL, which is very interesting.
So Minivel IOL, I'm going to talk about this Minivel IOL by CFI, and I've had a very good experience with this IOL. And I was never satisfied using multifocals or trifocals, because you don't know which patient will be really unhappy and come back to you and say that, doctor, I can't bear this. We have all had these problems in the past, and EDOFs brought a new fresh perspective of giving a good functional intermediate vision with basically I started using these lenses for my early glaucoma and mild diabetic retinopathy patients where I could not use my multifocal IOL. So that is how I introduced these lenses, and most of the cases that you see are mostly the patients where I could not do a trifocal. So and it has worked beautifully well in this subgroup of patients, because now we can give a premium IOL option in the form of EDOF to these patients which were not fit for a trifocal, and actually I am shifting completely to EDOFs now, and my trifocal numbers have reduced drastically because we have some wonderful array of lenses available now. So a problem with conventional multifocals, bifocals, that intermediate was not that great. And then came trifocals, where problem is you see best when you hold that object at the particular focus and not in between. So a patient had to really learn where to hold things, and if you see yourself as a patient, you can imagine how difficult it's going to be, where you have to hold things only at a particular distance to see clearly. And another problem was dysphotopsia, loss of contrast sensitivity. I'm sure all of us have done a lot of multifocals and faced unhappy patients because of these problems. As Dr. SOURABH said, there are a lot of EDOFs available now. So pure EDOFs are spherical aberration based, like Minivel or VVT. This pinhole one is still not available with us. Then hybrid multifocal diffractive, that is Symphony. I think a lot of us have already used. Again, problem was with a Symphony was little halos and glares that patient face, and they are never happy with a near vision. Then hybrid multifocals, like sir has already talked to us about Lucidis, and Lentis M+X is another very good candidate, and which I also love using these lenses with a mix and match, that they have Comfort and M+X, 2 lenses that Dr. SOURABH is talking about. And then the hybrid multifocal refractive diffractive, that is Technici Energy, that is another my favorite lens, along with other lenses available, because it gives you a very strong near focus. So you can't see, every patient is different, and you have to talk to the patient, understand his needs. Because you have so many available, you can give a patient a lot of choice now after discussing, and do what best you feel is good, whatever is good for the patient. So it's a single piece spheric biconvex hydrophilic hydrophobic copolymer lens. There is nothing special about this lens in injecting. It's so easy to inject with 4 haptic design. If you just tap the lens down, it will just go into the bag, and it's a preloaded design. But as Dr. Kumar has shown beautifully that sometimes there is a tendency to flip. So it's always good to have a second instrument in the eye when you are injecting the lens. It is a wavefront engineered lens. The spherical aberrations are inducted in the central pupil, the center of the pupil, that is the central part of the optic, and the peripheral part controls the high aberrations, giving a presbyopic correction. Just to elaborate, the central part of the lens has positive spherical aberrations, the surrounding collar has a negative spherical aberration, and the peripheral part will actually have the IOL power. So interplay of these spherical aberrations create an array of foci, and it acts like a continuous focus. So and it works primarily in the intermediate zone. You can see comparison of Minivel and Symphony. You can see for the intermediate part, Minivel performs slightly better than Symphony, minus all the halos and glares and other problems which we had with the Symphony. If you compare defocus curves of these Minivel, Panoptix and Etilisa, you can see Minivel is performing much better in the intermediate zone where others are dipping down. This is typical trifocal design where for an intermediate zone, trifocal performance dips and it picks up again for the near. While Minivel, you can see there is a continuous drop, but for intermediate, it's a great lens. And when you compare contrast sensitivity at higher spatial frequency was lower in patients with aspheric EDOFs than those of monofocals. Obviously, monofocals will give you much better contrast, but if you see from these charts, Minivel performs pretty well until there is a very when the spatial frequency goes as high as 18, only at that point monofocals tend to be a little better than Minivel, but for all practical reasons, I think Minivel gives excellent contrast sensitivity. And multifocals would do far worse than this, believe me. So Minivel is very close to monofocals when it comes to contrast sensitivity. And halos and glares have always been a problem with multifocals, trifocals, and if you compare all four, Minivel seems to do the best for mesopic vision. Photic phenomenons, most of the patients only complained of mild to moderate, but I think they are quite tolerable practically, and I have hardly had any patient complaining about the photic phenomenon. They tolerate it extremely well. Again, Dr. SOURABH also highlighted that point that light loss. So that the light loss makes a difference when patient is reading in a little low light conditions. And many times when multifocal patients come back complaining near vision problems, you have to tell them please hold things in a bright light and then you will see everything, because there is a obvious almost 15% light loss when you are using a multifocal lens, where it comes down to as low as 5% in these Minivel or other EDOF lenses. So since there are no rings on the optics, there are hardly any halos and glares. So these 60 eyes, we have done more than them now, but we had a better data of 60, so I have included this. So 90% did quite well. So it was almost N10 for near, and we had to give 1.5 to 2 diopter add for them to read very comfortably even in little low light conditions. So patients did quite well. Key is counseling. If you tell them very clearly that this is for intermediate and not for near, but nowadays with our changing lifestyles, lot of work is done at an intermediate level, and most of them accept it very happily. That once you tell them properly and counsel them properly, they know what to expect, and I've had extremely happy patients using this lens. Contrast sensitivity we measured at 1, 3 and 6 months post-op, and all the contrast sensitive values were in normal range. There was no severe subjective disturbing symptoms. That I have also shared that study, which also said the same thing, that halos and glares are very negligible. And when we gave them a questionnaire, then overall satisfaction was very high, and most of them would recommend the same lens to their colleagues. So if you see this typical defocus curve ranging from 0 to minus 1.5 defocus, it offered excellent vision, and only beyond 1.5 it starts dipping down a bit. And these are some other studies that minival IOL provided good post-operative functional results for fast and intermediate, and there was no dysphotopsia in this group of patients. And even post-LASIK, this works really well. When they compared different lenses for post-LASIK patients, Minivel and Symphony did better than Implus in the previously myopic LASIK eyes, and in previous hyperopic eyes, Minivel seemed to provide an acceptable intermediate and distance vision. So even the EDOF lenses are my choice of lenses in post-refractive surgery patients. Like I have done it post-RK, I have done it post-LASIK, and patients have done extremely well on these lenses. So I have stopped putting multifocals in my post-refractive surgery patients. And now they have another addition called Minivel Proxa,
Dr.
which I
Nitin?
have unfortunately not used. And the combination of these lenses would work very well. You can see Proxa is helping for a near vision. And thank you very much. I think other lenses we can discuss as we.
Thank you, Dr. Nitin. I would like to request Dr. Nagvekar sir to prepare the presentation. Just in the meanwhile, while we transit, Dr. Nitin, any particular experience about this IOL that you would like to share, like any negative experience you had with this design?
Only thing, IOL power calculation, I've had a little myopic surprises initially that my patients had -0.5, -0.75. If I targeted emetropia on my IOL master printout, so I started going little +0.5 on, so that then I started getting bang on the result. So you'll have to optimize your A constant, but otherwise it's been a perfect lens. I mean, after a long, this was the first lens which I was really happy with, and then came Comfort, and then came VVT, and now you have a wide choice and fantastic lenses.
Thank you.
उनके पास में. Okay. Yeah. So thank you, Saurabh, for this wonderful opportunity to discuss EDOFs. I know this was a last-minute inclusion course, but I think a well decided course. This is the need of the day and the hour. Okay. So I'm going to share with you my little experience with the Vivity, which I've been using for some time. It principally uses X-wave technology, in which instead of splitting light, as you see in diffractive IOLs, it causes a stretch of the focus so that one is able to see things from distance to intermediate to almost functional near. Now, there is complete utilization of light, and no light is lost when you use this particular EDOF lens. Hence, the lens provides excellent contrast sensitivity, and the patient can see very well even in dim light. The visual disturbances are no more than an ordinary monofocal, and it's a forgiving IOL, and this is a very important point. It's a very forgiving IOL in case of inability to achieve emetropia, especially when you have those cases of the hyper mature intumescent cataracts where it's difficult to get an exact IOL power. The only thing, as Nitin said, that in all these EDOF lenses, the patients need to be counseled regarding the need to wear low-ad reading lens. So now I'll just play a small video which explains the mechanism. I thought the video explains it better than I can. Volume. Volume.
This video on the mechanism of action of the Acrosoft IQ Vivity IOL.
Volume.
The Acrosoft IQ Vivity IOL
Okay,
is
I'll go
a
on.
first of its kind, non-diffractive presbyopia correcting IOL that utilizes X-wave technology to stretch and shift the wavefront. Acrosoft Vivity IOL utilizes essentially all light energy, giving patients an extended focal range with a monofocal visual disturbance profile. The Acrosoft Vivity IOL's
Volume.
X-wave technology consists of two smooth surface transition elements in the central 2.2 millimeters of the IOL. The first surface transition element is a slightly elevated smooth plateau that is about 1 micron in height, and the second surface transition element is a slight curvature change.
In this region.
With presbyopia, the focused light falls behind rather than on the retina when looking at close and intermediate objects. The slightly elevated smooth plateau is responsible for stretching the focal range. The small curvature change is responsible for shifting the continuous extended focal range to the anterior side of the retina so that a full range of vision is provided to the patient. The two smooth surface transition elements work simultaneously to stretch and shift the wavefront, creating an extended focal range, providing 20/20 at far, greater than 20/25 at intermediate, and 20/32 at close distances.
Okay, so basically, there are certain factors we have to remember. There are many ocular factors which make it impossible to implant any of the trifocal lenses. So what are those ocular factors which are forgiving in case of this lens? Dry eye and ocular surface disease, patients with mild glaucoma and macular disease such as a grade 1 or a 2 ERM, unilateral cataracts. It's a great lens for unilateral cataracts, especially in young pre-presbyopic age group patients. When the patient has a monofocal IOL in the other eye and desires a little better range of vision, post-keratorefractive surgery, and I'm going to show you at least 3 examples of those, and minor inaccuracies in biometry, as I mentioned earlier, when it's not possible to get an accurate biometry. Now, there are certain patient factors which are not contraindications to Vivity. So your demanding patients, your type A personalities, those who are fearsome of reported nighttime visual disturbances, those who are habitual night drivers by profession, and those who work in dimly light environments. When you should not put a Vivity, you should not put a Vivity in patients who desire prolonged close vision, where monovision or mini monovision may not be adequate, where there is a severe loss of central vision, and when there is significant zonular laxity. So now I'll share my brief clinical experience. I must confess that I don't have the large volume that many of our esteemed colleagues on the dais have, but I started implanting this lens from the 30th of Jan 2021 in the midst of COVID. It was very slow initially because we didn't have the toric model. So far we've implanted 81 IOLs till the end of April, till 30th April. So we have got a range of follow-up from 1 month to 16 months. So there were 53 lenses implanted in 2021, out of which 22 were bilateral and 9 were unilateral. And in the first 4 months of this year, we have put in 8 bilateral lenses and 12 uniocular lenses for a total of 81 lenses. And if you look at the distribution of the torics to the non-torics, you can see that we implanted 45 torics as compared to 36 non-torics, which emphasizes the need that in all cases of multifocal or extended depth of focus lenses, you need to address the astigmatism very, very carefully. You must remember these are aspheric IOLs, so even a small amount of residual astigmatism in any aspheric IOL is not forgiving because it highlights the higher order aberrations that patients may have. If you look at the gender distribution, there are 55% females as compared to 45% males. I would have thought that more males would take this, but yes, like all trifocals, the females are a little more, at least in my group of patients. Now, these are the results of the uncorrected visual acuity at all distances. And as you can see, that as far as the uncorrected distance visual acuity is concerned, 20/20 was achieved in almost 87.5% of patients. 20/20 for intermediate was achieved in about 75% of patients. And if you combine the 20 and 25, if you combine the intermediate and the distance, it goes well past the 95%. And if you correct the distance, like if you do the best distance corrected visual acuity at all distance, the combination of the intermediate and the near goes almost to 97-98%. Now these are all carefully selected cases. There were no really ocular comorbidities which might have caused any degradation of vision. So the results have been extremely good and we've been extremely satisfied. Our patients have been extremely satisfied. And when you get something like 95%, you feel so confident of this lens that you can almost implant it in anybody. Now, there are some cases that I thought I'd discuss with you. This is my very first patient. He was a 60-year-old business.
Can you sum it up in 1 minute?
Yeah, so I think we'll go to the cases later if you want. Yeah. Just to sum it up.
Maybe you can highlight one case. So
I'll highlight this particular case because this is a case which will be, this is a case which is very interesting because it is close to our heart. This is a 52-year-old phaco and refractive ophthalmic surgeon. He had myopic LASIK in 2009 for -8.5 diopters, approximately. His pre-op best corrected vision was 6.9 in the right eye, N6, and 6.12 N6 partial with -3 and -3.75 diopter respectively. He had a grade 2 nuclear sclerosis in both eyes. Obviously, being such a a well-read surgeon, he didn't want a trifocal or a monofocal also. I offered him a monofocal. I insisted, but he said, no, I would like to go for the vivity. That's why I've come to you. So the uncorrected visual acuity in the right eye was 20/30. This eye was the second eye. He chose to have a myopic overcorrection of minus 0.75. I was telling him minus 0.4 is what I'll go for, but he insisted I want a minus 0.75 since I want to read. His left eye, he achieved 20/20 vision. Binocularly, he was 20/20, both with uncorrected and best corrected. His visual acuity in the right eye showed a refractive error of minus 0.75. With minus 0.75, he was 20/20. Important part was that his uncorrected and as well as best corrected intermediate visual acuity is 20/20. He's operating every day. He's driving every day. His only problem is that he can't read so well. He's very fond of reading newspapers, and he's a voracious reader. So while he reads most of his books on his iPad and things like that, as far as near vision is concerned, intermediate, he takes an addition of 1.25 despite doing the minus 0.75 in the right eye. But he's doing quite well. And his near vision is 20/20 partial in that particular eye with unaided. So he's very happy, and he's one of us, a guy who does LASIK and phacosurgery every day, and that's the little thing that I wanted to highlight. So in summary, it provides excellent distance and intermediate vision with functional near vision. Trifocals, though, provide better uniocular near vision as compared to the Vivity, and Vivity visual disturbance profile is better than the trifocals and similar to monofocal IOLs, and so it can be considered for the demanding patient. Those desirous of spectacle independence and unsuitable for trifocals can now be considered for the Vivity with some adjustment for monovision. And if cost were not a consideration, I think the Vivity could replace all monofocals going forward. Thank you so much.
Thank you, sir. I invite Dr. SOURABH to talk about this technology of Oculentis, which he told me about, and I have used more than 200 by now, and it's a wonderful lens. It will be very interesting to listen to SOURABH's experience.
So the initial plan was to also have a panel discussion, but I think we are running short of time. So I would like to just briefly introduce this particular lens, and then we'll try to discuss a few case scenarios. Ye chalu hai? No.
Any experience with Ray 1 EDOF? Ray 1 EDOF? No, I'm not.
I have done
ये क्या close क्या? Okay. Hello. Yeah. Yeah, sure. So I will be talking about Oculentis EDOF. I will just skip through basically the material is same like what we have seen with Zeiss. That's a hydrophobic surface and hydrophilic material, and they use the submicron lithium technology. So good thing is that it has a very sharp edge, and I have not seen any PCOs in my 1 year of use. And basically it is different from other IOLs because it is asymmetric EDOF. That means one part, the lower part is for near and upper part is for the distance when you implant it this way. You can implant it in various other ways also. My practical experience is that though it says that it's a refractive bifocal by design, just stop the noise. It's a varifocal IOL. That means the transition zone between the distance and the near which they have created also gives some amount of intermediate vision. So this is how it looks, that from the near, the light is focused on the macula from the lower segment, and the upper segment focuses for the distance. These are different types which are available in this particular model. The ones which I like are the Lentis Comfort and Lentis M+X, which are available in India. But Lentis Comfort more so because it has a wider central, you can see, distance zone of 1.15 mm. That means any patient having even larger angle alpha, they will not lose any vision, they will not lose any contrast. At the same time, it has addition of plus 1.5. So the transition zone is much smoother. M+X is good for someone who is a avid reader. It has plus 3 addition, but you can see the central zone is just 0.8 millimeter, the left side. And that's why there will be some loss of contrast sensitivity if the angle alpha is not appropriate. So this is all basically how it is. You can see the upper one is the monofocal, so they are happy with the distance, but they are not happy with the intermediate. But with Lentis Comfort, they are happy with the distance as well as intermediate. M plus, there will be some area where for the intermediate there will be loss of vision, but near is good. So generally my technique of doing this, so these are the results of the Lentis Comfort. What I do, you can see the fourth one, Comfort Binocular. So you can do a blended vision. That means one eye targeting emetropia, other eye minus 1.5, and they can have similar to what we do in Presbyond. That means a blended monovision because they have extended depth of focus. But I don't use that way. What I do is that I target little bit of myopia even in the distant dominant eye, and might be slightly little bit more myopia in the near. So it's like minus 0.25 targeted for the distant dominant and minus 0.5 to 0.75 targeted for the near dominant eye. So that reduces the problems of monovision, that is loss of stereopsis, etc. So what I found out in my patients, I will just forget about the slide. What I found out with these patients is that the dysphotopsia are hardly any. Nobody has bothered about dysphotopsia. The contrast sensitivity is excellent, as good as monofocal IOLs, which we tested even on Pelly-Robson chart. We have to, slightly modify our A constant. For example, the modify A constant which company gives is 118.2 with the SRKT. And what I target is 118.5. That means I target minus 0.3 for the rather than targeting emetropia or hypermetropia. And for the other eye, I see the result of the first eye. If it is, and the autoref reading it will give, if we have targeted emetropia is around minus 0.75, okay, not 0. So when I got minus 0.75 in the autoref post-operatively, what I will do is that for the other eye, I will target minus 0.75. Okay, if I get minus 1 in the first eye, then I will target the same in the other eye. Okay, so the patient has very good distance as well as near vision. And my experience with EDOF or any newer technologies, hydrophilic IOLs give much better, crisper vision as compared to hydrophobic IOLs. That is my personal opinion. I think it might be because of the surface, which is much better, or the maybe refractive index, which is much lower with the hydrophilic IOLs. So this was the comparison of photic phenomena. You can see the oculantis have very, very minimal, severity. So not just the amount of dysphotopsia, even the severity is quite less. The typical, what they complain is of the angel wing. Okay, angel wings means around the light on the lower part. If the near eye is lower, they see a kind of, fan of light, which is very mild. And particularly they will see it during night driving, but still they can drive at night very easily. Regarding the, the position of the IOL, how you can put, the typically recommended is the left side position. That means near eye is lower, okay, but my experience is that it doesn't matter with Lentis Comfort because it has a smooth transition zone. The idea is that if your lens is like this, slightly infranasally the near eye, the photic phenomena are towards the near eye. That means the angel wing will be infranasal. And when it is infranasal, it will not affect your night vision. Okay. For near, it doesn't matter if there are some photic phenomena because we don't, read in dark light. So that way it helps. Just a brief video, but I think I will just summarize because I want to, I think Kumar Doctor has shown it's not a very difficult lens to put in if you have experience of plate haptic IOL. It's same to that. It's a very soft material. You can tuck it in. Of course, you should avoid, very small rexes like 4 mm or something like that. But 5 mm rexes, you can easily put it inside. And this is how I do. I just rotate it in vertical position, then tuck it in. You don't have to dial the IOL in. And use 1% hyaluronate so that there is no viscoelastic which is remaining. So I will skip the video and we'll quickly move on to some cases because I want the panelists to discuss, because it's more important in instruction course to discuss their experiences rather than just giving some theoretical, information which we can read otherwise also. So let's start with I think one of the very important cases Dr. Nagwekar sir has shown, post-refractive patient. So, and ophthalmic surgeon. Okay. So this is a very common scenario that nowadays we face. Okay, 45-year-old computer professional, and they will either have bilateral cataract or unilateral cataract. So, okay, just within 30 seconds, just give your opinion, like, which one you will go for in such scenario, which lens?
I'm very concerned about patients' complaints of pillows and glows. So my first choice is EDOF. or unilateral, I would love to do a EDOF because that will give him a good intermediate vision and which is halos and glare free. And 45-year-old, I would do a VVT because my experience with VVT has been fantastic. It's a great lens, and I hardly have to give him near ads also in many patients. So I'll just give plus. Binocularly.
Yeah.
Binocularly, I hardly have to give them a reading ad in VVT patients. So
next-
the most I'll give one.
Next case scenario, very common again, 25-year-old with traumatic cataract in one eye. We consider that patient has good potential vision, good pupil.
Yeah, I think again, my choice would be an EDOF. Absolutely. I mean, in fact, I said almost every case
Yes.
if one is
Every case.
concerned about the quality of vision.
Okay, 65-year-old housewife who uses mobile, doesn't read much, no driving.
I would use mix and match like dominant eye comfort, non-dominant eye Implus-X, or VVT and Proxa, but I have not done more of Proxas, but mix and match is a good case for a mix and match.
I think I would think of a trifocal in this case.
Trifocal is a good choice.
It's a good choice.
55-year-old businessman, I would occasionally drives at night. Bilateral cataract, will stick to bilateral cataracts.
So again,
Occasional driving, yes.
yeah, no, even if he's occasionally driving, 55-year-old businessman, he'll work more with his computer and his mobile. So I think I would put an EDOF in this case.
Nitin, trifocal EDOF. Okay.
EDOF, yes.
6-year-old who has habit of reading a lot. Very simple.
Trifocal.
But I love to do mix and match, you know.
Okay,
rather
so
than
mix and match is
trifocals.
another, and trifocal, of
It
course,
works
where
beautifully well.
both. Perfect.
What would you mix with? Which two
Comfort
lenses?
dominant, Implus-X non-dominant, or Minivel and Minivel Proxa. I have done very few.
Minivel Proxa, what is your?
I have just done.
62-year-old farmer, profession, not much of reading, no driving, very short in height. Why the short in height is very important?
Because
The near reading is very close.
Yeah,
I
yeah.
would go for a trifocal or very high addition.
Yeah. If he
62
doesn't do reading, maybe a monofocal also.
yeah. So of course, monofocal is out of question now with EDOF. 62-year-old professor by profession, not much of reading, no driving, very tall in height.
I think I would put in a trifocal Zeiss. Zeiss trifocal. You know, their intermediate is 80 centimeters. So if he's very tall, I think I would do that.
50-year-old surgeon, I think he has already answered that. 50-year-old lawyer who with reading work, not much of driving.
I would put an EDOF because I don't want him to sue me for any problems.
40-year-old shopkeeper.
I think intermediate is important for everyone. So most of EDOF, the beauty of EDOF is it fits in all categories. So you really don't have to scratch your head. You can just put EDOF and sleep peacefully.
About shopkeeper, they have to read MRPs, which are really small fonts. So you have to
Yeah.
be really, you have to speak with them what they really want. I think regarding ophthalmic conditions, we have already spoken that these are, apart from the ones which cause decentration of lens, I think most of the cases we can go ahead with EDOF IOLs. Of course, it's case to case basis. I think the time is already finished, but if there are any questions, I think high angle alpha is one of the things, whether you would go for a particular lens when there is a high angle alpha.
Again, I think my experience with high angle alpha in EDOF lenses has been very good. I mean, while I would be very critical of or very wary of using a trifocal, with an EDOF, I think you can. I have done a high angle alpha. I think the lens was around plus 30, if I'm not mistaken, and it did very well. Yes.
Any questions from audience? Otherwise, I will just. Yeah, I think I had.
Ophthalmic
kept
surgeon, EDOF. Yeah, he was minus 8.5. No. The VVT does not. VVT is on the IQ platform. So it can adapt to capsular bags of any size. It's available from 10 to 30.
Regarding high myop and high myop, one thing we have to understand is that. That's okay.
It's available. It's a
whenever you are using lens in high myopia, understand that the actual near addition which the lens gives is reduced. So if you are giving plus 1.5 addition lens, they will require more near. So high myopes, lower IL power, you should use higher add lenses. Hyperopes, it is opposite. That's why hyperopes are very happy with multifocal, because their the effective near addition is much more than actually which is there in the IOLs. Okay, so this is just about the optics which are there. So I think the next session is going to start soon. Okay. Thank you so much. I think I'm, of course, will be there to answer many questions outside the hall. Thank you, Dr. Nitin, Dr. Nagwekar sir, and Dr. Kumar. We had very short notice to prepare this presentation. We were in, he was in Srinagar, I was in Northeast, so I'm sure we made. Thank you, sir.